everyone, to the webinar introducing ICRP publication 153 on radiological protection in veterinary practice. We're so happy that you've joined us today. I'm Dr. Nicole Martinez. I was one of the co-chairs on the task group that developed this publication, and I'm currently the vice chair of ICRP Committee 4. I'll be your second presenter today. For my day job, I'm an associate professor at Clemson University, which is in South Carolina in the United States. My original co-chair, Ludwig von Blotto, couldn't be here today as he's enjoying his retirement on a bike trip across Europe. But we're very thankful for all his contributions. My recent co-chair, Aste Sovic, Dr. Aste Sovic, will be our third speaker today, and she's on ICRP Committee 3. She's both a veterinary radiologist and a physicist. She's a diplomat of the European College of Veterinary Diagnostic Imaging and also holds a PhD in radiotherapy physics. She has previously worked as an associate professor in veterinary diagnostic imaging at the Norwegian University of Life Sciences, as well as head of research at the Norwegian Radiation and Nuclear Safety Authority. Currently, she works as a consultant for the veterinary teleradiology company VetCT, as well as in private practice, and also does radiation protection consulting. Our first speaker today is Tony Davila, who was our task group mentee. He's the radiation safety officer at Tulane University in New Orleans, Louisiana, which is also in the United States. He obtained his master's degree in health physics from Louisiana State University, where he first became interested in radiological protection within veterinary medicine while studying cats undergoing I-131 therapy. So with that, Tony, I will turn it over to you.
All right, thanks, Nicole. So good morning, everybody, or good afternoon, good evening, depending on where you're joining us from. As Nicole mentioned, my name is Tony Davila, and I'm going to be giving everybody a high-level overview of ICRP publication 153. So first, I want to introduce our wonderful task group members. I'm not going to list everybody out by name. However, I do want to mention Debbie Gilly, who isn't pictured here. And I do want to emphasize that we have a wide range of backgrounds in our task group. We've got radiation protection specialists, nuclear physicists, medical physicists, veterinary radiologists, oncologists, regulators, researchers, ecologists. So, we had input from people of different backgrounds to make sure we kind of could cover the depth of this topic. And so here are the contents of both the publication and the presentation I'm going to give today. I'll basically be giving you kind of like a brief guided tour through the document. And so even before the introduction, we have this why this publication section, because we thought it was important to provide a summary of the motivation for the explicit consideration of radiological protection in veterinary medicine. So why now? Well, first, we should understand the history of the use of ionizing radiation in veterinary medicine. Veterinarians were some of the first adopters, quickly realizing its benefits shortly after Röntgen's discovery. Early on, most applications, strictly plain film radiography. So it was fairly easy and simple to limit risk with, just a few simple rules: time, distance, and shielding. Fun fact, actually, the chair of the first and second Radiological Congress was a veterinarian. His name was Dr. Eberlein, and he was actually a close friend of Röntgen, the only veterinarian to ever hold the honor of chairing the Radiological Congresses. But since that time, applications have diversified and grown. Due to a variety of factors, such as the onset of digitalization of radiography, an increase in secondhand equipment that's available for veterinary use, but also an increase in veterinary dedicated equipment. And as well as those economic factors, there also are societal factors at play, such as recognizing the importance of animal welfare and recognizing the human-animal bond. The figure here kind of demonstrates some of the benefits from the human-animal bond interaction. Nowadays, many animals are considered a part of the family. But even if they don't quite hold that status, for many, working animals can be a source of livelihood. And then when it comes to things like endangered species and exotics, we consider conservation and rehabilitation efforts important. And so in all of these cases, the owner or animal guardian, wants their animal to receive the best possible care. And oftentimes this will entail some sort of radiological procedure. Right. And this is kind of widely recognized. Many places have laws against animal cruelty. Here in the United States, New York was one of the very first to pass any such law back in 1829. And also we realize this importance in research, right? We have the 3 Rs for animal research: replacement, reduction, and refinement. And so there's this increasing awareness of the interconnectedness between humans, animals, and the environment. You may have heard of the One Health approach that essentially emphasizes the importance of health in humans, health in animals, and the health of the environment are all connected. Then we have the introduction, where we kind of go over the objective and the scope of the publication and kind of elaborate more on the historical background and modern motivations that I just briefly mentioned. And so basically our objective was to introduce issues surrounding radiological protection in veterinary practice due to the advancements, increase in interventional radiology, nuclear medicine procedures, and even radiation therapy. And then how we can apply the ICRP framework to manage these issues. And it's important to note the publication is intended for a wide-ranging audience. We want it to be useful for radiological protection professionals, veterinary staff, students, anybody involved in education or training, and even members of the public who may be interested. And so that'll bring us to the chapter on basic concepts of radiological protection, where we briefly review dosimetric quantities, the biological basis of radiological protection, and the different protection strategies that are available. Again, it's intended for a wide-ranging audience, so the publication does go over things like absorbed dose, effective dose, activity, different types of exposure situations and categories. And of course, we talk about deterministic and stochastic effects in animals. The chapter on ethics and values reviews the ethical basis for the system of radiological protection and kind of makes connections between the ethics used in radiological protection and ethics in veterinary and environmental issues. I'll just talk about this briefly because I know Nicole is going to touch on this more. But I just want to say that, we can take the ethical values and kind of extend them and interpret them in ways that align with veterinary ethics. And the purpose is to make clear the interrelationship between the ethical values in radiological protection and in veterinary practice. And so chapter 5 is unique aspects of veterinary practice, where we discuss similarities, the large similarities between human medicine and veterinary practice, but also highlight the differences and how this presents unique challenges in veterinary medicine. A lot of times it's due to the operational environments that are required when dealing with animals, and also the different combination of personnel and members of the public that may be involved. Chapter 6, application of the system of radiological practice to veterinary medicine. That's just a discussion of the protection principles of justification, optimization, and those constraints in the context of the animal patient, as well as the workers, public, and the environment. So you may recall that for exposure categories, we have occupational, exposure that you get through your job, medical exposure you receive either as a patient or a volunteer, or perhaps a caretaker to a patient. And then public is kind of for basically exposure categories that don't fit into occupational or medical. And then for exposure situations, it can be planned. We know it's going to happen ahead of time, and we can calculate reasonable doses. It could be existing, as in there's already a radiological hazard, and we have to then manage or control it. And then emergency, which is an unexpected situation that will require urgent attention. And protection of animals in context of environmental protection addresses the collective impact, such as the preservation of species and maintaining biodiversity. But as currently written, the medical exposure category only applies to human medicine. So then where does the animal patient fit in? Veterinary applications of ionizing radiation are largely comparable to human medical exposure, but because the exposure happens to a subject that isn't a human, it's not considered a medical exposure. So it's largely left up to however the local government or regulatory agencies decide to manage that exposure. This could lead to issues, however, if, for example, you decide to manage it as an industrial exposure or something in that realm, then it could lead to an approach where the animal is considered an object and you're not really taking into account the fact that it's a sentient living creature. And so the commission now specifies that the system include the protection of the individual animal in special circumstances. An animal patient undergoing a radiological veterinary procedure would be such a case. And of course, further discussion would be needed on subjects such as animal research subjects, and then pets and domestic animals in the event of a radiological emergency. Chapter 7, summary of recommendations and considerations, is a review of the key takeaways of the publications, which I'll kind of go over briefly. And so, as I said in the beginning, the objective is to provide an initial set of recommendations for a wide-ranging audience. There are unique radiological protection challenges in veterinary practice. Again, this is due to different operational environments and different combinations of personnel involved. And the priority is still that of the humans involved. However, we do want to explicitly consider the exposure of the animals, because they're also subject to detrimental effects of radiation. And as I've mentioned before, the ethics values align between radiological protection and veterinary practice. The ethics include things like animal welfare, sustainable development, solidarity, reverence for life, stewardship, respect for autonomy, and empathy. And because applications in veterinary practice are comparable to situations in human medical applications, justification, optimization, and those constraints are still our friends. We don't have to necessarily reinvent the wheel. And just to kind of end things, we do have 2 annex sections. The first is roles and responsibilities, where we discuss the individual and organizational functions and the anticipated obligations that are relevant to radiological protection. Because as we all know, radiological protection requires commitment at all levels, from the top of the organization all the way down to the person performing the procedure. And then if you consider yourself a hobby philosopher like myself, you'll enjoy Annex B, which is ethical issues associated with the protection of animals in the environment. And there we kind of elaborate on humanity's relationship and responsibility to animals and the environment. Some of the interesting topics include things like, in human medicine, there's 2 parties, the doctors and the client. In veterinary medicine, there's typically 3, the veterinarian, the animal patient, and then the client, who is typically the animal's owner and guardian. And so in this scenario, who does the veterinarian kind of owe their responsibility to? Is it their patient or their client? And then we discuss things like the morally relevant differences between humans and animals, and things such as animal welfare. And that pretty much wraps up this tour of the publication. I hope I gave you guys a good idea of what's in there, and that you guys will go out and seek it out. Thank you so much.
Great. Thank you so much, Tony, for that excellent introduction. I'll go ahead and share my screen. I'll be speaking today a little bit on the unique aspects of radiological protection in veterinary practice. So Tony gave us a great overview. He went through this basically table of contents, and you'll notice that unique aspects have their own chapter, but I'm going to be drawing from a few different chapters because really the unique piece of veterinary practice is really threaded through the entire publication. I'm going to reiterate some of our key takeaways and elaborate on that in terms of some of this unique pieces of veterinary practice, some similarities to human, but then what sets that apart? What are some key challenges or some unique challenges? So first, I did want to mention that radiological protection of workers in the public has always been included in the system of protection, including in veterinary practice. That piece, that protection of workers in the public in veterinary practice, that's not new. That's always been incorporated in the system of protection. Those folks always included. Now we're just explicitly addressing it. They haven't had their own publication yet, so to speak, but they always were included, and now they're explicitly addressed because of the modern advances that Tony mentioned, these new challenges that have come up. The veterinary patients here are just a few examples, come in all shapes and sizes. In addition to that, we have technologies and modalities. If you can think of it for people, probably it's available for animals as well. And so with these advances in technologies, these modern modalities, the complexities and challenges associated with that, you have corresponding radiological protection challenges as well. And that's what we say, and I echo what Tony said, that now we need explicit attention to this, and we're drawing explicit attention and giving specific guidance and our philosophy behind radiological protection in veterinary practice. And again, as Tony said, we can have these unique challenges. Often that arises from the nature of dealing with and caring for animals. We have different combinations of people and members of the public who may be involved, various operational environments when dealing with animals. So for example, on the previous slide, you saw pictures of animals basically in the clinical setting. Most of those, except for the horse, were at Colorado State University's veterinary teaching hospital. So you might have a large hospital with a ton of different expertise, from veterinary radiologists to veterinary radiation oncologists to nuclear medicine technologists to all of that, a medical physicist maybe. But you also have smaller clinics that you might not have all that breadth, that variety of dedicated expertise. And so the situation and the people involved are going to be different. There may be some cases where the animal's owner, it's warranted for them to help in a procedure, whether that's maybe helping calm the animal or something similar. There's also the use of mobile radiographic equipment that's pretty standard in dealing with large animals that could be performed at farms, in stables, at auctions, in open fields. And so one of the challenges there, for example, would be delimiting a safe working area. And you also want to make sure that there's the proper use of the mobile equipment. Anyone who happens to be involved, you want to make sure that they are appropriately informed of the appropriate behaviors, potential risks, if any. And so that's pretty common for mobile radiographic equipment. Nuclear medicine diagnostics treatment's not so common at a stable, but if they are, they need to really consider contamination. So for example, some therapeutic interventions might be performed outside veterinary clinics, like if a radioactive substance is administered into a horse's joints at a stable, you want to be concerned about potential contamination issues. So this is what we're talking about when we're talking about the variety of combinations of personnel, members of the public, environments in veterinary practice. Also, as Tony mentioned, the ethics of our radiological protection system, our core and procedural values described in publication 138, they can be applied across the different applications of radiological protection. So in this publication, we made an effort to really draw the connections between veterinary environments and then also medical applications of RP, because we have the link to medicine and that we're caring for a patient, even though it's an animal patient. We also have a connection to the environment, as we have an animal in our care. And also we're trying to protect animals in the environment. Although the protection endpoint is different, there are some commonalities now. We also have veterinarians who may be working in an environmental context for conservation or preservation issues. So there's the connection there as well. So as Tony promised, here's a little bit more discussion of the ethics and values with this additional interpretation for veterinary environment and the medical application. Beneficence and non-maleficence is doing good and avoiding doing harm. And for our interpretation of that in veterinary, we link that to animal welfare. So animal welfare is, as it sounds, promotion of health and welfare of an animal. We want to minimize suffering in animal care. I've also highlighted the extension of dignity here as reverence for life. Reverence for life is basically this idea that life is precious, that both humans and other living things have value and importance. And if a life has to be sacrificed, if something like that has to happen, it really needs to have a good reason. So sometimes we do things related to animals that aren't in the animal's interest. We consume animal-based foodstuffs, for example, but we want to make sure we're still taking that minimization of suffering and respecting the life and having good reason. This would also apply, for example, to research animals. And then we start making a little connection to the environment with accountability. Accountability, transparency, and inclusiveness are our procedural values, whereas the first four on the left are core ethical values, because it's not just what we do, but it's how we do it. And so we have this animal welfare and reverence for life, and we have a responsibility. That's where the stewardship accountability comes in. Responsible use and management of things entrusted to our care. So if we're thinking of veterinary practice, probably immediately what comes to mind is our companion animals, our pets. We have a responsibility to take care of our pets, but maybe also that's livestock. And then thinking even broader than that, responsible use of the land or natural resources. This is where the environmental aspect comes in. But then if we're thinking in terms of biomedical, we have personal information or medical information. So stewardship can have broad application and kind of a little more, but nonetheless, a little more specificity to that accountability piece. So let's move to justice and prudence. Justice, our extension is solidarity. Solidarity is the unity arising from shared responsibilities, interests, and sympathies. And so in this context, implying the co-expertise process. So working all together, we want outcomes to be fair, equitable, and balanced. And justice does have a lot of different flavors, right? We can even go to environmental justice, which would be a link, fair distribution of risks and harms in the environment. But in the end, what we're looking at is things are fair, equitable, and balanced, and coming together to ensure that, and working together to ensure that. Sustainable development, meeting the needs of the present without compromising the ability of future generations to meet their own needs, whether that's societal, economic, environmental. And we relate that to prudence because we can't necessarily guarantee or see what the future holds. So we have to act with wisdom. We have to act with precaution, particularly when our decisions might affect future generations. And so sustainable development, we're familiar with the United Nations Sustainable Development Goals, but we also have pieces of that. And are we making sustainable use of our equipment and facilities? So there's a big piece there as well that can tie to prudence and sustainability. And then finally, we have transparency and inclusiveness to mention. Respect for autonomy is an individual's rights to have control over their life and make informed decisions. And how are you going to make informed decisions without transparency? So in respect for autonomy, we link this to open and honest communication from the transparency procedural value. Because we want our owners in veterinary practice to be able to make informed decisions. The risks, the benefits, the financial obligations, all of that, they want the information they need to be able to make an informed decision for the care for their pet or livestock or whatever it is. But similarly, workers need to know their risks and benefits as well so they can make informed decisions and act appropriately and prudently in the course of their work. So there's all of that related to respect for autonomy, owner, handler, and workers. That's relevant for that as well. Also of note, respect for autonomy, justice, beneficence, and non-maleficence are the principles of biomedical ethics, the classic ones. A lot of times, autonomy is connected to dignity. And as Tony mentioned, there's a lot of interconnections here between these principles. These aren't one-to-one, it's just how to help us think through these ethical values in our application. And then we have empathy, which is basically sharing and identifying the feelings of others. And we apply that through meaningful engagement, appreciation of needs, challenges, and values others. That goes a lot with solidarity, where solidarity is more, you can think of that as group-based, and empathy is I think of it as more individual-based. And that's so we have mutually agreeable outcomes, inclusiveness. That's the one that's connected to. All right, and then one of the last key takeaways that I'd like to emphasize, again, echoing Tony's presentation, the priority is protection of humans. Asa is going to talk about protection of the animal patient, and there's a large focus in the publication on that because that is new to the ICRP. But that's not to say that people are taking a back seat, right? So the priority is the humans involved, but we are considering exposure of the animals as well. We also note here that radiological protection should be approached with a holistic perspective and a graded approach. So our focus here is radiological protection, but it's only one of the issues that have to be managed in veterinary practice. There's a lot of things going on, even just in safety. For example, there's a lot of commonalities with human medicine, as we said. So pediatricians could be bitten or scratched or kicked like a veterinarian can, but a kick from a horse is probably going to be a bit more severe. So of course, veterinarians need to prioritize their safety as well. So that's just one example. There's other aspects of safety as well, but RP should be taken with a holistic approach. And so tying to the system of protection, and again, Asa is going to elaborate on this, the 3 levels of justification used in medicine can also be applied to animal patients. But of course, we also consider if the associated occupational or public exposures are justified as well. There are some slight differences. That's the bit that I'm going to highlight. On that, you'll notice that we have defined group of animal patients in that level 2 justification. And also we've added in the management of the patient. And one of the reasons for that is because unlike for humans, non-medical investigations are quite common. So for example, for insurance purposes or our pre-sales exams for a performance horse, or a screening radiographs for hip dysplasia in puppies, for example. So these aren't necessarily medically indicated, but are pretty common. And so there's a difference there in justification, but it would be very useful to have guidelines for when those things are justified. Currently, there's a lack of decision support tools like referral guidelines or appropriateness criteria, which will be very useful, in particular if there's not a veterinary radiologist handy. But with that being said, that such decision support tools need to be developed collaboratively. So national and international professional veterinary radiology societies, professional bodies, animal health, regulatory authorities. So this would require some commitment, but would nonetheless be very useful. And then as Tony mentioned, we briefly mentioned research animals in this work, but we defer to the broader research ethics, replace, reduce, and refine. That's considered a bit beyond the scope. And then moving to optimization, which is aimed at achieving the best level of protection under the prevailing circumstances through an ongoing iterative process. Of course, priority, as I said, is humans, but largely this optimization can be achieved by limiting the exposure of animal to what's necessary to achieving the clinical objective. So bonus. This does encompass animal welfare. We talk about as low as reasonably achievable, taking into account economic and societal factors. Well, the economic application might be that for a performance horse, whereas the societal bit might be related to companion animals, but that animal welfare piece, that veterinary piece is still aligned there within the optimization of protection. We want it to best fit the circumstances. Again, each situation is going to have its own unique pieces that that need to be considered in the overall determination of what is reasonable, of what is optimized, what is prudent. The whole environment, the owner's wishes, the location, the available equipment, all of those things need to be taken into consideration. The patient themselves, the animal patient themselves, needs to be taken into consideration. So similarly, as I mentioned, that there is a lack of decision support tools, we also don't have things like diagnostic reference levels. And so to develop diagnostic reference levels in the same sense as used in human medicine may be quite challenging. That might be too much, but that idea could still be used. We could still draw from that experience to develop something similar, to start collecting dose descriptors and start making those comparisons. It might not have to be as robust, but that type of information could be very useful. Dosimetric data for patients in particular is limited but emerging. Asta is going to talk a little bit more about that. And then another unique challenge of optimization is deciding on anesthesia. Sedation or anesthesia could help from a radiologic protection standpoint, reducing exposure or dose of the individuals involved. But depending on how long it is, depending on the animal's health status, it could potentially be a detriment to the animal's health. So decisions should be prudent based on whether or not or when to do sedation or anesthesia. And I just want to share kind of a quick example about that. So for veterinary positron emission tomography, the figure on the top shows two different methods. M1 and M2 are two different methods for performing veterinary PET positron emission tomography. For the first, the radioisotope is injected prior to induction of sedation or anesthesia. So the animal is held quietly during that uptake period. Then the scan is performed, and then there's the recovery period. And the second method is to induce anesthesia first and then do the injection. And so you can see the advantages and disadvantages listed here, but particularly from a radiation standpoint, that dark bars, there's 3 dark bars on the top and then kind of 2 dark bars on the bottom, that is when you're in close proximity to the animal. So this is where your dose rate would be the highest. So you can see from method 2 that the advantage is a reduced radiation dose to staff. However, you have additional anesthesia, you have increased costs, you have increased equipment and room use. So there may be a circumstance where method 1, which streamlines patient handling and shortens anesthesia time, is preferred. And just to give you perspective, occupational dose associated with veterinary PET, the blue line, the top line, is for veterinary. And this was an average of 19 patients with an average mass of about 22 kilograms. So on average, about 9 microsieverts per procedure. And then the bottom is an average of 12 human studies with human patients. So although these are approximate confidence intervals, and you can see they overlap, but the veterinary dose is going to be a little bit higher on average than that in human medicine. And so this bottom figure is for method 2. So method 1 would be a little bit higher than that. However, if we do extrapolate out to an annual dose, at the caseload at the time, we're still less than 1 millisievert in a year. So these aren't high doses that we're talking about. And just the picture on the right, something else to mention about optimization, as you can see, this is the recovery, the animals being recovered from anesthesia. And in the bottom picture, this particular patient needed a little bit extra care. So they struggled a little bit more coming out of anesthesia. So the technologist had to spend more time with the patient, which is totally appropriate. So their doses were slightly higher than average, which is fine. That's where that judgment, that's where that prudence comes in to say, yes, this is warranted for the animal's care. The doses are slightly higher, but everyone acted appropriately within the broader scope of optimization. Switching gears just a little bit, but still thinking about people and their relationship to animals. A carer in human medicine is an individual who can be exposed to radiation as a helper providing support or care for a patient. So typically a partner or a loved one of some kind, to helping out someone who's undergone a nuclear medicine procedure, for example. Animals on the whole, as Tony mentioned in his presentation, are often not legally recognized as patients, but there is a direct benefit both to the animal patient and to the owner from this relationship. And there are studies in the literature that show this, that show the benefit from having a companion animal. So ideally, it's kind of like with the diagnostic reference levels, there's not going to be an exact parallel, right, in veterinary medicine. But this idea of an owner handler maybe being able to get a little bit higher dose than what would otherwise be allowed because of this benefit should be considered. So this could be tailored within reason in veterinary practice. For example, when considering length of hospital stay, a really long hospital stay is not necessarily good for the animal. And in particular, if this animal patient is the owner's lone companion, there's a detriment to the person from being away from the pet for an extended amount of time. So obviously this has to be a case-by-case basis, but we think there's really some added value to this. If an exposure of an owner handler therefore is deemed justified, dose constraints should be used to guide optimization in a proportionate, practical, reasonable way. So the bottom line then, we have some differences that I've highlighted, but there are a lot of similarities to human medicine and also non-medically indicated human imaging. Veterinary applications should be treated in a comparable, proportionate way, meaning that this is medicine, even though our patient is an animal instead of a human. We also in this want to consider equipment and education and training. So for example, veterinary equipment is often secondhand, so it might not be the exact right fit for the facilities that they have, and so that might need to be adapted. Dedicated equipment is often for, the standards are often the industrial standards, and ideally the standards should be for medical devices rather than just industrial. Similarly, for education and training, specific applications like interventional radiology, nuclear medicine, radiotherapy, should be reserved for professionals that can demonstrate completion of education and training program. We want the necessary knowledge, skills, attitudes for adequate care of the animals, obviously, of course, but while also being able to take responsibility for radiation safety aspects, because there are practices that do higher dose modalities and procedures that don't necessarily have this specific training. And so in the end, we hope that by highlighting these concerns and knowledge gaps will inspire additional research and development, evidence-based use of ionizing radiation for veterinary practice. We want to support the justification process. Would love to see dedicated facilities and equipment, improved understanding of radiosensitivity of different types of animals, and practice guidelines, supporting practice guidelines for exposure management, other relevant areas to promote health and safety of personnel, the general public, the environment, and also further improving the quality of care for patients and healthy animals submitted to radiological procedures. And just from my perspective, a couple of things I think I would like to share. These are things that folks have kind of asked me about along the way that have some ties to veterinary practice, but didn't quite fit in this publication. So we'll see what comes next, but consideration of livestock decontamination following an emergency, where service or comfort animals fit. So if a human undergoes a nuclear medicine procedure, how does the comfort animal fit into that? There's other working animals. You can see a picture on the right, a police dog here, search and rescue animals. And then, as I mentioned, research animals were beyond the scope. And is there further discussion there? It remains to be seen. And then this, just if you'd like to take a screen cap of this, some resources I think would be interesting. The publication 153 is largely kind of a big picture approach, general recommendations, as Tony mentioned. For practical guidance, the IAEA has a great publication out. You can scan that QR code. And there are some review papers here as well as the environmental effects database that you might be interested. And with that, I'll finish it out. Thank you very much, and I'll turn that over to Aste.
Thank you very much. And I will share my screen. There we are. And I'm going to talk about what's really new in the publication 153, which is radiological protection of the animal patient. Now, Nicole talked in some detail about the ethics of radiation protection and how its application to veterinary medicine. So I thought I'd just reiterate a little bit about those factors that are relevant for radiation protection of the patient, because sometimes the question you get is, why should we care about radiological protection of animal patients? One of the obvious reasons for it, it's animal welfare, that we want to promote health and welfare along with minimization of suffering, such as adverse effects from exposure to radiation as far as possible. There's also the reverence for life, recognizing that not only humans, but also animals are important and have a value regardless of their usefulness for humans. They also have an independent value and importance. Then there's the stewardship, that the responsible use or management of things entrusted into our care, such as the animal patient. And also respect for autonomy. So I've outlined here the right of individuals to know risks and benefits in order to make informed decisions. And I think particularly in veterinary medicine, there's very little communication with the owner. In this case, obviously the animal won't be able to make that informed decision, but the owner to communicate to the owner about potential risks of different radiological procedures and allow them to make informed decisions. Then some common misconceptions that you often encounter in veterinary medicine is that with respect to the stochastic effects, that animals don't live long enough to get radiation-induced cancer, so we don't need to care about, the low-dose effects because they're not relevant. And I've heard this one frequently, even from veterinary radiology imaging diplomats. So it's a very common misconception, and I'm going to address it a bit in more detail. And there's also sometimes a misconception that, well, at least we don't need to worry about tissue reactions because radiation doses in veterinary medicine, they aren't high enough to produce such tissue effects. And I think that stems a little bit from previous uses of veterinary or radiological procedures in veterinary medicine, where there were mainly x-rays. An animal patient might get a few x-rays in their lifetime, but that was it. But as both Tony and Nicole have detailed here, it's really diversified at the moment, and we do have high dose applications in veterinary medicine at the moment. So to address the first misconception, and that is animals do get radiation-induced cancers. One of the important radiobiological concepts here is that cancer patterns in mammals are similar and relative to lifespan. So cancer, different types of cancer, will have shorter latency periods for animals with shorter lifespan. Example of this is, for instance, the bimodal age distribution of osteosarcoma incidence in humans and dogs, where dogs have a peak incidence between 6 and 8 years of age, so corresponding to middle old age, and a smaller peak at 18 to 24 months, which corresponds to this human peak incidence at late puberty. And it should also be noted that much about what we know about radiation carcinogenesis has actually been derived from animal experience. And these experiments, they clearly demonstrate radiation carcinogenesis in these animals. Some examples are membrane neoplasias in rats, radiation-induced, or myeloid leukemia in mice. And if you were to follow the don't live long enough, these animals have really quite short lifespan, but they do get radiation-induced cancers. And there's been a large number of studies investigating this, and that includes some large canine studies. After the Second World War, there were some quite big studies in canines that looked at this, and they had both internal and external exposure, and they included in utero and neonatal exposures as well. So you can see here in the the lower panel, that was for external exposure, and they've looked at all tumors and also malignant tumors, and looked at the age at radiation exposure. so days postpartum and post-conception. And as you can see, there's quite a high sensitivity here at 55 days post-conception to 2 days postpartum, which should be of interest to veterinarians in particular, because we do tend to, or it's still common practice in many places that you do radiographic examinations of pregnant bitches to count the puppies in actually the time where they're highly or the most sensitive. And the upper panel, you can see a study that was done with internal exposure of beta emitters. They're quite high dose rated here, so some of the dogs even died of deterministic injury. And the highest doses here were to lungs and then bone, liver. And they saw, particularly for osteosarcomas, that they had the highest, or osteosarcomas and hemangiosarcomas, that they got the highest incidence of radiation-induced cancers. And this study here in the lower panel, it was a big study, as I mentioned. It was 1,680 dogs. So often in veterinary medicine, we're used to these small studies, but these experimental studies here were big. And there's also been shown that we do get radiation-induced cancers in a clinical setting, just as we do in human medicine. And there's been a study, for instance, published on radiation-induced osteosarcomas in dogs that have been treated with radiation therapy. So Gillette et al. In 1990, they had a look at dogs irradiated for soft tissue sarcomas that developed osteosarcomas within the radiation field. And there's also an example here, an image of an osteosarcoma of a dog 5 years after treatment for mast cell tumor. Now, this one is also in a typical location for a primary osteosarcoma, but the ones that they saw in this study by Gillette was actually they found the sarcoma osteosarcomas in the radiation fields and in very atypical locations for primary osteosarcomas. And the latency period in the study was between 1.7 and 3.2 years. And it should also be noted that only 22 of the dogs survived long enough to be at risk. So it was actually quite a high proportion of the dogs that did survive that got these radiation-induced osteosarcomas. And they also included a study with experimental intraoperative radiotherapy and external beam radiation. They combined those two in normal dogs. And of those, 7 of the 27 developed osteosarcomas within the field, radiation field, and also this was in location lumbar vertebrae and psoas muscle, so typically not where you tend to see these primary osteosarcomas in the dogs. And then, as we mentioned, high-dose procedures, they're increasingly adopted in veterinary practice. We have radiation therapy, so both external beam radiotherapy. There's still some orthovoltage systems in use, which have some particular concerns when it comes to particularly skin effects. And there's also some that use cobalt-60 sources, and there's increasingly also adaptation of linear accelerators into veterinary practice, veterinary radiation oncology, with even such applications as tomotherapy, intensity modulated radiotherapy, stereotactic radiotherapy. And brachytherapy is also being used. You can see down here, there's a cat before, during, and after brachytherapy for a soft tissue mass at its the medial angle of its eye. And there's also radionuclide therapy. The most common application there is iodine 131 for hyperthyroid cats, but there's also sometimes used for other applications, such as thyroid carcinomas in dogs, and often with a more experimental angle, you have different radionuclides as well that are being used. So the figure here in the lower right, that's a dog that is lined up for intensity modulated external beam radiotherapy with a linear accelerator. And there's also an increasing use of interventional radiology for a variety of different purposes, such as vascular, urinary, respiratory, gastrointestinal, cardiac, orthopedic. And in a recent study, Hirsch Boyle et al., they had a look at exposures, but in terms of fluoroscopy time and also the radiation exposure associated with it. And as you can see, there was a wide range in fluoroscopy time, ranging from seconds to 85 minutes, so 1 hour 15 minutes, and also a large range of radiation exposures, up to here almost 618 milligrays. And they found that the vascular and cardiac applications were the ones where you had the highest doses. While in radiotherapy, obviously, you're in curative doses, so you can have doses up to 70 grays or in a fractionated scheme. And it should also be mentioned that radiotherapy in animals often is hypofractionated because you want to minimize the number of anesthesia events. And we do get tissue effects in radiotherapy, both acute and late effects. So you can see to the left here, a dog that's first it's before radiotherapy, and then afterwards you can see 3 months afterwards it's being aligned for a PET scan for both of those two images. And you can see here the leukotrichia, so its skin, the hair is turned white within the radiation field. So it's not aged that much in 3 months. It's actually the whitening of the fur due to the radiation. And then you have acute effects, such as in the middle image here, a radiation treatment burn 1 week after the chemotherapy for nasal carcinoma. And to the right, you can see an example of fibrosis 3 years after hyperfractionated radiotherapy for a mast cell tumor. So we do get, just like in radiotherapy in humans, we do get late effects, and we do get tissue reactions. And there are also accidents, but very few cases are reported. There are variable local and national requirements for reporting incidents involving dose errors that affect the veterinary patient only. But there is one study, an example that was actually reported, in which a stereotactic radiotherapy plan was created for a canine patient in August. But at the time, it wasn't delivered since owners opted for medical management. But then as disease progressed, a new treatment plan consisting of a single fraction stereotactic radiotherapy followed by full course IMRT was created in November. And the first single fraction stereotactic radiotherapy was delivered uneventfully. But at the time of the first IMRT fraction, erroneously, the original stereotactic radiotherapy plan from August was loaded and the first fraction of this plan delivered, instead of the first fraction of IMRT plan. So there was around 370% more dose delivered than intended for that day. So 10 grays versus 2.7. Luckily, majority was to the tumor. But still, it's the unique thing about this case was that it was actually reported and published. And a lack of requirement for reporting may create the impression that incidents and accidents don't occur in veterinary medicine, but they do. And Nicole mentioned some of the unique aspects of veterinary practice, and I'll reiterate a bit on those related to protection of the patient. When it comes to competence, there's quite a limited radiation protection training in veterinary education, and often both image acquisition and interpretation is performed by non-specialized staff. And high-dose diagnostic as well as radiotherapy procedures may be performed by practitioners without accredited and certified specialist training. And when you having in mind the images of the tissue effects that you may see, I think it's very important that people who do this kind of procedures do have the appropriate training for it. And also there is very often lack of involvement of medical physicists. And then when it comes to equipment, there's often secondhand equipment from human medicine that may be sometimes used without adequate quality assurance. And as Nicole also mentioned, specialty veterinary equipment may fall under industrial rather than medical standards. There's also a lack of regulatory harmonization. There's a lack of guards against self-referral and self-presentation. Self-presentation in the meaning that the owner here presents for an imaging procedure without the intervention of a veterinarian. And self-referral is that the owner of the equipment, the one who benefits economically from it being used is also the person referring to the radiological procedure. In human medicine, in many places, there are guards against that the person referring to, for instance, a CT exam cannot have an economical interest in that exam being performed. And we do also have the lack of referral guidelines or appropriateness criteria that will support justification. So how do we improve the radiological protection for our animal patients? Well, it's the general framework is still valid. We need to ensure that all radiological procedures are justified and optimized. And again, we have this important for the patient is the level 2 that for a specific procedure and objective. It will improve the diagnosis or treatment of a defined group of animal patients or provide necessary information such as hip dysplasia status, for instance. And it should also do more good than harm in management of the individual animal patient. So justification is an important factor here, is balancing benefits and risks. And in a study by Kelsey et al. In 1998, that was entitled Epidemiological Studies of Risk Factors for Cancer in Pet Dogs, they even ended up with a recommendation that dogs should not be exposed to, or they should be exposed to radiation only when the expected benefits will outweigh the risks. Now, the benefits and risks are not only those to the animal. The animal will benefit from improved diagnosis and treatment. If it's for instance, pre-purchase examination, it will be a benefit to the animal that is actually suited for intended use. You can have early detection of subclinical disease or improved population health through screening programs. But they do also risk stochastic effects, tissue reactions, or misdiagnosis or inappropriate treatment. And the veterinary staff will obviously have the professional satisfaction of being able to provide the best possible care for their patients. The customers will be satisfied, and they will get financial revenue from the procedures. But they're also at risk for stochastic effects and even tissue reactions when you talk about interventional procedures if they're not done in an optimized way. And owners and handlers have both emotional and economic benefits of improved health of their animals, but could be at risk of stochastic effects when if they're present during examination to use to assist, for instance. And for the general public, society, and environment, you have the control of zoonotic diseases, as well as economic benefits of healthy working and production animal populations. But with nuclear medicine, you'll also have the risk of environmental contamination. So all these factors have to be taken into account when you decide whether something is justified or not. So how can we ensure that medically indicated procedures are justified? Well, firstly, there's education and training, making sure that the veterinarians are referring to and performing these procedures are aware of the doses and associated risks from the various procedures, and are able to perform risk communication with owners and handlers. Decision support tools such as referral guidelines, appropriateness criteria, they would be very useful, and they should be easily accessible, free of charge, easy to use, ideally integrated into an electronic medical record system. But they need to be developed collaboratively. So national, international, professional veterinary radiological societies, veterinary professional bodies, animal health regulatory authorities. And it will take a substantial commitment of time and resources to create and update such decision support tools. And the radiology requests also need to be comprehensive. So they should contain sufficient clinical information that the radiologist or any internal or external auditor can assess whether a particular examination was justified. And finally, when you're adopting new types of radiological equipment, so either human equipment that's being, you're starting to use it for veterinary purposes, or you have dedicated veterinary equipment, the potential implication for radiological protection should be assessed, and it should be considered whether it's justified to use this equipment. And then in veterinary medicine, it's very common with non-medically indicated investigations, which are imaging of asymptomatic animals for purposes other than medical diagnosis and treatment. such as hip and elbow dysplasia, radiographic screening programs in dogs, standardized radiographic examinations for stallion approval in equines, and pre-sale radiographic examination of racehorses, competition horses, pleasure horses, as well as radiographic examination for insurance purposes, for instance. And these may not always be consistent with the current clinical evidence. So this is a field where level 2 justification is particularly important, and where I think appropriateness criteria would be very useful. Because a given procedure, it should be suitable for detection of the condition in question, and also for screening a large number of animals. So this means, for example, it's common in equine practice, in pre-purchase examinations of warm blood riding horses, that you'll include specific radiographic views of the navicular bone, because it's not uncommon with this palmar foot pain in these animals. With the advent of standing MRI, we do know now that there's a lot of soft tissue structures as well in that region that might be the cause of pain and lameness. But standing MRI for every single warm blood that's going through a pre-purchase examination, that would not be feasible. So that's just an example of a procedure, or an imaging radiological procedure, that is, we have to also look at what's feasible, not only what's available. And it should also be a demonstrable relationship between the imaging findings and the goal of the screening. So, for example, if you're doing a breeding suitability examination, the trait that you're looking at should have a sufficient degree of heritability, as well as prevalence in the population, so that it's a relevant discriminator between breeding animals. And another example is, for instance, if lesions that can be dissected by giving imaging procedure, will they have a known impact on the competition's ability to perform their work? So will it affect performance? Then we have optimization, and that's always aimed at achieving the best level of protection under the prevailing circumstances through an ongoing iterative process. And with the increased lifespan and prevalence and frequency of radiological examination in companion animals, that increases the need for optimization. Now, adjusting imaging exposure parameters or adapting the active that's administered with radiopharmaceuticals so that you achieve the required clinical effect at the lowest possible radiation dose. That will reduce the dose to the animals and often also to humans. But it's important that you maintain diagnostic or therapeutic quality. So optimization is not equal to dose minimization. If you have underdosage, you may get non-diagnostic study, has to be repeated, or you might miss clinically relevant lesions. So in general, the appropriate design and construction of installations should be ensured, and you should also be careful in selection of equipment. You have the day-to-day strategies, such as education and training of staff. There need to be clarity regarding roles and responsibilities, who are responsible, for instance, for quality assurance of the equipment, who should talk to owners about risks, etc. And you need to have routine performance tests of equipment and a systematic application of procedural rules. We don't currently have diagnostic reference limits, but as Nicole said, the general strategy could be useful. And it's also important to take into account other factors, such as other occupational hazards, kicks, for instance, bites, and the clinical condition of the animal, if it will actually be able to withstand sedation or anesthesia. So you should ensure that equipment is fit for purpose, and if it's designed specifically for veterinary use, it might conform only to industrial standards that may be insufficient from a radiological protection perspective, such as reduced shielding, internal shielding in portable radiographic equipment to make it lighter. And then you should limit the radiographic views and body areas imaged to those necessary for the given diagnostic protocol. And here again, referral guidelines or appropriateness criteria and standard protocols for common situations would be of great usefulness. Avoid repeated examinations that don't give a clinical benefit. Access to previous examinations taken at different practices could be useful. And the digital imaging helps in that, obviously. Then to develop technique charts for the range of animal sizes relevant to the facility, and also to limit the exposed tissue volume to what's relevant for the clinical case. So collimation in radiography and fluoroscopy, and scan length limitation in CT. But we do need more dosimetric data. So particularly for potentially high dose procedures, such as interventional radiology, fluoroscopy guided surgical procedures, CT interventional procedures, and dynamic CT examinations. And there's a need for systematic reporting of dose descriptors for clinically relevant protocols, such as dose area product or CT dose index. That you need some way of, if you are to optimize the protocols, you need to be able to compare protocols between institutions. And there's also a lack of knowledge about relationship between dose descriptors, organ doses, and associated radiation risks that will need to be determined for veterinary medicine. There are already some animal-based voxel phantoms available, some Monte Carlo simulations. Now, as Nicole mentioned, there's a big range in sizes and types of animals that we encounter. So having this, we obviously won't be able to have something as robust as in human medicine. But for instance, cats are relatively similar in size. When they have different weight, it's usually a case of body condition rather than the very large range in sizes. And dogs do vary, but certain clinical conditions and thus certain imaging and examinations are more common in certain types of dogs. For instance, you tend to get sinonasal neoplasias in large breed dogs, and extrahepatic portosystemic shunts are the congenital ones in small breed dogs, as well as brachiocephalic obstructive airway syndrome. So you might want to start to focus on the common procedures and common conditions that will often be limited to certain sizes of animals and types of animals. Then you have optimization in veterinary radiotherapy. Optimization is crucial in all radiotherapy because you have those high doses to target volume, and you need to deliver high dose to get the desired therapeutic effect, while you want to keep the exposure of other tissues and organs as low as reasonably achievable. You want to avoid the deterministic effects as far as possible and limit the overall exposure of healthy tissues to reduce the probability of second cancers. So these are complex high-risk procedures that should be performed by veterinarians with extensive training and education in radiological protection. For instance, specialists such as diplomats of specialty education and training programs. And the providers of these programs should ensure that radiological protection is an integrated part of their curriculum. And additional data is also required in radiotherapy. First of all, you need to ensure completeness of reporting of treatment planning. So factors such as radiation dose, treatment delivery, quality assurance, adjunctive therapies. And these are currently insufficient in a large portion of published veterinary studies. There was a recent study by Kehler et al. Who showed that none of the studies they investigated had a level of completeness consistent with ICRP guidelines, and only 24% of them reported more than 50% of the items evaluated. So here we obviously have a responsibility of journal editors and reviewers as well to ensure that published studies do conform to recommended reporting guidelines. There's also a variability in contouring of target volumes in normal tissues. That must be addressed because it may contribute to different tumor responses and normal tissue toxicity in a given patient. And there are also variations in different fractionated protocols, even for curative intent and the same condition, such as several protocols for osteosarcoma in dogs. And we do need prospective clinical trials in veterinary radiation oncology to assess clinical outcomes. There's currently quite a great reliance on retrospective data rather than those prospective trials. So for those interested in some further reading, I've added some references here. And I'd like to thank you very much for your attention.
So much, Austin. I think we have, if we need it, I think we have about 20 minutes of time for questions. We have been answering some of them live. Perhaps we might start with the open questions, Austin, that I left for you. And then if we have time, maybe we can read some of the questions and answers otherwise. And if you have questions, I think Charlotte Kelsey, correct me if I'm wrong, you can put them in the QA feature down next to the chat button if you see it.
Absolutely, yep.
Great. Oh, I'll say you're muted now.
There we are. Yeah.
Yeah.
I will start with the first question, which is there radiotherapy protocols for animals for different types of cancer, or if euthanasia is recommended? And yes, there's absolutely different radiotherapy protocols for animal patients that are in use. Euthanasia is always also a valid option because not all owners may live in an area where there is access to veterinary or radiation oncology facilities, and they might not be able to afford it because there's with an extensive protocol is quite an expensive treatment. But absolutely there is for those who live in areas where it's available and they have either they're able to finance it themselves or it's covered by their insurance. They do have that opportunity. Yeah. And dose limit per day radiotherapy session less than 2 grays, treatment doses used higher. Often, since it's hypofractionated radiotherapy, in that they use in human medicine, you often have this 2 grays per fraction fractionation scheme. And you can have many. So for head and neck cancers, you can have, for instance, 35 treatment fractions per 2 grays. That would be 35 anesthesias over 7 weeks, 1 per day, Monday to Friday in an animal patient. So that's typically not done. So you tend to be hypofractionated. For instance, 18 fractions is one of the treatment protocols for head and neck cancers, and then they tend to have perhaps 3 grays per fraction, or sometimes even more. So, and when you go to stereotactic radiotherapy and even more conformal ones, you can go even higher, depending on what your radiation. Yeah. Let's see. We have information to share on where to report incidents, as well as incident levels. Where incident levels we don't know much about because they're not reported. And I think a good starting point, of course, it would be to report it to the institution where you work. And institutions particularly where these high dose procedures are being performed, I think they should have in place a reporting system. And also, I think it would be a good idea to report it to your national regulatory authority, even if it's not required by law. It would be a good thing to do. And they might also be able to help you in figuring out what happened because they have this experience from the human medical field. And it also might bring to their attention the fact that there is actually these things going on in veterinary medicine. Then there's another question, if it's possible to perform radiotherapy treatment without anesthesia. It depends on what your radiotherapy treatment is. If it's iodine therapy for cats, for instance, you don't necessarily need to anesthetize, or they're typically not anesthetized. They might or might not be sedated, depending on the protocol at your institution, but they're typically not anesthetized. You just inject subcutaneously the iodine 131 and then put it in a cage and gets absorbed by the thyroid. While if you're doing, say, for instance, IMRT, then it's absolutely vital that the animal patient is completely still during therapy. So for external beam radiotherapy, you would typically have the patient anesthetized. And while in brachytherapy in equines, for instance, there might be some application where the horse is sedated, so might not necessarily be anesthetized, but it would be sedated to ensure it's standing still. But then the probe is inserted into the tumor, so it will move with the animal. But for external beam radiotherapy, typically anesthesia, because it's it's very high doses and very often very close to organs at risk that you wouldn't want to be irradiating because the animal starts moving during the session. Yeah, let's see. There's a question about pet here. Would you like to answer that, Nicole?
The question on, I'm not sure exactly. It says how to decide the lethal dose for pets. Maybe that means what the appropriate radiopharmaceutical doses for the imaging. But because otherwise I'm not sure the context of the question.
Yeah.
If I'm remembering correctly, at least for the radiopharmaceutical dose, like megabecquerels per kilogram, I think it was something like 6 megabecquerels per kilogram, but I would have to double check that.
Yeah.
In terms of dose to the patient, I don't have, there's not a lot been done with respect to that. There has been some done, but I don't have those numbers off the top of my head.
Yeah. Let's see. And then there's a question about radiotherapy patients, so such as radioiodine patients. Advised to maintain distance from humans for some days for protection. Sometimes require, whether they should remain apart from their pet dogs or cats.
Depends on who you talk to, and it depends on the situation. So particularly if there are young children in the household, that might be a different conversation than if it is an elderly person who's the only person in the household, right? That's used to having the cat sit on their lap or whatever the case is. So there is a lot of judgment in those decisions, and that goes back to prudence and also taking the whole situation in the context that you're given. So there's not, I think, one hard answer, one bright line that you would specify for that. But there was another question that something similar, but in the United States, they are pretty particular about what you do. They give you information about what to do with cat litter or what to do with feces or what to do if the animal throws up. And they also, in a lot of cases, will have to sign something that says you agree to not sleep in the same bed with the animal if you want to take it home. If you refuse to do that, then you don't get to take the animal home until X amount of time has passed. So I personally think that perhaps that's a little too rigid. That's my personal thought. So that really is going to be also up to the regulatory agency to decide.
Also, I think this question actually is about the patient, whether they should stay away from their pets as well as other humans after
human radiotherapy patients.
Yep, because they're advised, as it says here, to stay away maintain a distance from humans for some days. Should they also maintain distance from their pet dogs or cats? It's a good question.
It's a good question.
Yeah, absolutely. I think personally, at least if I had a pregnant bitch or cat at home, I would definitely maintain distance. And then with the dog or cat, I guess it's depends on how long. If it's a cat that likes to sit in your lap for hours and hours, that could perhaps be a bit of a concern. So
that goes to I'll say the animal as a comfort or carer in a hospital as a therapy. It's very similar question.
Yeah. Because obviously it would be could be very stressful for the animal too to be kept away from its owner. So let's see. See any comments on ethical radiation protection issues associated with oral administration for feline radiotherapy? Typically, no commercial supply of iodine for injection. Is this a global problem? I'm not aware if it's a global problem at the moment. I think the problem with oral administration in cats is that it's not always that easy, because cats tend to be a bit particular about oral administration. And also hyperthyroid cats, one of the side effects of being hypothyroid is that they can get a bit vicious and a bit grumpy. So then you have they won't be the easiest patients to administer these oral treatments to either. Then there's a question on any publications highlighting stochastic effects of repeated diagnostic doses of radiation, and not to my knowledge at the moment. Anyone who's looked at that, they have been higher. Although in some of those studies on those canine studies from the 60s, 70s, 80s, they were down to the millisievert or milligray rather exposure range at least, but not the microsievert that you might expect in diagnostic procedures.
Yeah, there are some, if you look in publication 123, I agree with Aste's answer there, but there are inclusion of those like review articles that have a lot, like kind of summarize a lot of the studies that have been done with respect to effects, including stochastic effects like cancer, but also other types of effects. So I guess I can, some of the questions that we answered typing, I can answer those orally. There were a couple of questions related to the idea of a veterinary care or someone caring for an animal. And just to clarify that, those folks are still considered members of the public. So they're subjected to whatever the public dose limit is or public dose constraint. We do recommend some flexibility there, but that's just a recommendation. If there wants to be some flexibility, that's going to be up to the regulatory body. But we do anticipate making a recommendation, or I anticipate that the new set of ICRP recommendations will offer that flexibility in their recommendations. But again, it's not going to be exactly the same as it is for people, but again, within reason to add some nuance there. And then there was a question about the method 1, method 2 for the positron emission tomography, when you induce anesthesia, if you're inducing anesthesia versus when you inject the radiopharmaceutical, and how you make the decision, what the prevailing principle is. And I gave my standard nuanced answer because there is a lot of nuance there. There's a lot to consider. There's advantages and disadvantages to both, or pros and cons to both. So ultimately, that decision is going to be the responsible veterinarian. In a larger facility, probably you have a team of people to help make that decision. But it might be different depending on different clinics. Different clinics are going to have different resources. Different clinics are going to have probably different priorities. And so there's kind of a balancing of the ethical values to decide which of those. They're both arguably fine. They're both acceptable methods, but which one you use is going to be up to that individual clinic. And then a broader context of, if we kind of a philosophical, should a veterinarian give their life for an animal? In general, I would say no. So human life in general is the priority, but that's not to say that I suspect that there are people who would risk their life for their pet, like run into a burning building after their pet. I'm not saying that that's what you should or shouldn't do, but there's probably people who are willing to do that. So again, there's this balance, right? Shielding requirements, and Asta, you might, or Tony, you might know a little bit better, but someone asked about shielding requirements, and our publication talks about shielding in the general sense, doesn't have any specifics. The IAEA publication does have a little more specifics, but in general, I think that's going to be specified, again, like the regulatory body would specify those shielding requirements.
Yeah, I agree. That's typically something that would be specified by our national regulatory authority.
Then I think there's maybe one last question. The question asked by radioiodine patients: how long should I restrict my contact with my pet after iodine therapy? Interesting. And that's in the same ballpark of questions, right? So I'm not sure what a good answer would be. Any idea?
No, well, as I mentioned, I think, well, at least if your pet is pregnant, I would restrict contact with it. And yeah, but otherwise, we don't have much good data at the moment about, we do have some ideas about potential doses to humans after their contact with animals who've been through radiotherapy, but what would the doses be to the pets after contact with the humans? It's a different question. Will be at the moment we just don't have the dosimetric data really to answer that. So it'd be an interesting study.
It would be, yes. All right, well, any last comments from our speakers today?
I was just seeing there's two more questions.
Oh, great, I missed them.
And use of portable equipment, recommendation for a safe distance for the other employees of the clinic and farm. While you have the general recommendations for the operating zone, that they shouldn't be within the actual the designated operating zone for the equipment that you would set up, and then there's different distances along the primary beam versus perpendicular to it. So those will typically be I guess most national regulatory authorities would have details on how to actually set up the operating zone and what how large this should be depending on your equipment. So there shouldn't be anyone who's not actually actively involved within the or involved in the radiological examination within the operating zone when they are exposing. It says a dose registry is kept for humans. Will it apply to animals in the future? It would be nice, but I think at least what we need to start with is to actually have some dose descriptors recorded for animals. And have an idea about what kind of exposures they're getting. But a dose registry for a dose passport, for instance, for an animal, I think that would be very far in the future if it happens. But I do think there's a need for more dosimetric data about the procedures. At the moment, mainly for the when it comes to diagnostic procedures, at least mainly for the optimization purposes, they can actually start comparing and optimizing protocols. But when it comes to radiotherapy and also potentially interventional procedures where you might have repeated exposures and high doses, then it would be I think it's something that should go into the electronic medical record of the animal, what exposure it has already achieved. And then there's a question on if personal dosimeter is compulsory in the US.
Great question. It depends. If your line of work, if you work with, let's say, radioactive material and you're anticipated to get less than the public dose limit in a year, you're not required to wear a dosimeter. A lot of people still do. But then otherwise, yes, you do individual dosimetry, right, Tony?
Yes, that is correct. And it's going to vary, at least in the US, it varies a little bit state to state, but there's usually some sort of cutoff that if the worker is expected to get that amount, then dosimetry is required.
And then do you also have area dosimetry in your hospital areas?
Yes, we do. We have a PET CT clinic where we have area monitoring around there.
And then also there was another question above that. Since effects take about 20 years to appear, is it safe to say that no restrictions apply?
Effects, I'm not sure if who effects on who. If it's effects on animals, they don't take 20 years to apply. That was my main point about this common misconception that since radiation effects in humans take maybe 20 years to manifest, then we don't need to worry about animals because they live so much shorter. But that's the thing, in animals, they will get these cancers with a latent period of a couple of years. So 2 years, perhaps 2-3 years. So since they have a shorter lifespan, they also have a shorter latency period for these effects. So no, it's not safe to say that they don't live long enough to get the potential effects.
Great. Well, thank you, everyone. Thank you to our speakers, and thank you for everyone who've been here today. We came to the end of our time. I will remind everyone that participants who attended at least 50% of the workshop will receive a certificate of attendance via email within 48 hours of this event. A recording of this event and slides will be available on icrp.org in the coming weeks. We'll also do our best to get the questions that were answered today up with short written answers if we can. And with that, thank you again so much for coming. We'll see you next time. Bye.